estamos aqui no contexto de um projeto de investigação financiado pela APSAI, que muito agradecemos esta oportunidade única de trazer cá a maior especialista na área do luto a nível internacional, Holly Prigerson. Este projeto é liderado pelo professor Neto, e era porque ele estava à espera.
Estava ali no corredor, ali em cima.
Ele esteve aqui durante o tempo todo, já está mesmo a chegar. Com a colaboração de outros colegas, nomeadamente Sara Albuquerque, que também estará a chegar, Ana Silva e eu, que é o Alexandre Coelho. O objetivo deste simpósio, desta conferência, é falarmos então sobre a perturbação do luto prolongado, e para isso trouxemos então a doutora Holly G, que eu passo então a explicar. A doutora Prigerson é professora na Royal Cornell Medicine e diretora do Cornell Center for Research on the End of Life Care. Ela recebeu muitos prémios e bolsas pela sua pesquisa a nível internacional e publicou mais de 400 artigos em revistas prestigiadas como a JAMA e a PLOS Medicine. A sua pesquisa contribuiu grandemente para a inclusão da perturbação do luto prolongado como entidade diagnóstica distinta de outras, nomeadamente da depressão e da perturbação do luto prolongado, no ICD-11 e mais recentemente no DSM-5 revisto. Ela desenvolveu também com a colega Wendy Lenchental um programa que nos chamou muita atenção por estar a apresentar grandes resultados. É um programa dirigido a cuidadores familiares em cuidados intensivos. Nós fizemos a aplicação desse mesmo programa no contexto desta investigação para Portugal, e é nesse contexto que trazemos aqui a Dr. Holly Prigerson. Now in English, we feel very honored in having you here with us. Thank you very much for accepting the invitation and to share with us your insightful thoughts about prolonged grief and empowerment. Thank you.
Thank you so much, I'm absolutely delighted to be here. I think I may have invited myself. So I'm happy, as we say, we're picking up what I was putting down. I'm really happy to be here. I've seen your beautiful city, your beautiful country, and I will try to talk slowly. I'll be presenting about prolonged grief disorder, about some of the controversies around it, some of the misunderstandings, which I recently published a paper on addressing the misunderstandings, and then there were misunderstandings of the misunderstandings, and so there's a lot of confusion about what this disorder is and is not. So I'll be going through it. I have a feeling you all have done your homework and have read most of the literature out there, but I'm happy to entertain your questions and hopefully answer them satisfactorily. And then the good part will be using what we know to improve outcomes with interventions like Empower. So I have a lot of slides, and we're probably not going to get through all of them, so I might skip around a little bit. The one question that I have for you all is, there are these video clips that include standardized patients and interviews with someone who, a bereaved person who meets criteria for prolonged grief disorder, who does not, who meets criteria for major depressive disorder, so you can distinguish depression from grief. But they're each about 5 minutes long, and so it ends up chewing into a lot of time. So I'll present the first one, and then we'll gauge based on your input on whether I should play the other two or not, or just continue through, because Empower is actually at the end of the talk, so I'll try to get there. I'm going to be a little bit in a rush, but we might want to forego those things. So without further ado, let me get to what the talk's going to focus on. We're going to talk about what prolonged grief disorder is, distinguishing it from the course of normal grief, or normal. Normal's a loaded term. We say typical. Now we say typical grief. The diagnostic criteria that are in DSM-5 text revision, a differential diagnosis, that's where the videos come in, and then addressing some of the misconceptions out there. My husband and I, Paul Maciejewski, we proposed this new, what we call a micro-sociological theory of adjustment to loss, which focuses on social deprivations. And you know, it's like when you're pregnant, everyone looks pregnant, and you see children. Now that we're focusing on the social losses of grief, all the research that I read, I'm like, see, it's a social influence. This is social, everything's very, you start realizing how interpersonal relationships really shape mental health in such dramatic ways, especially in the context of an interpersonal loss. So we'll be discussing the theory and its adaptations. And what are some of its adaptations? There's Empower, there's a naltrexone drug trial, which has caused a lot of controversy, and we've developed online interventions. One of them we call simpatico, which is to pair people who understand each other because of their like losses. So, without further ado, why don't we start by talking about the typical course of grief. Now, this was the first publication that I thought was not going to be controversial at all. We took out the people who had prolonged grief disorder from our Yale bereavement study, and all we wanted to do was follow their grief symptoms over time. Not pathologize anyone. Are there systematic patterns? We have the data to test it. What are the 5 indicators of grief? The DABDA, you know, disbelief, anger, bargaining, depression, and acceptance we think is a high bar, but we think integrations probably, or reintegration is more what the final stage is. So we had those 5 indicators, and we were assessing bereaved people over time from loss. I said, so we can look at what are the patterns? How does this change over time from loss? And just describe it. It's purely descriptive. And see whether these patterns that Kubler-Ross and Colin Parks, who recently died, advanced with John Bowlby about what these patterns of phases are what we call states of grief, because a person can return to those states. We're not saying once you've experienced one of the states, you won't experience it again. We just wanted to test, is there some truth, some evidence that supports the states or states of grief? Despite how controversial it was, we think that there are 2 aspects of the states of grief theory that are incontrovertible. The first is whenever you get awful news of a significant interpersonal loss or anything, the first psychological response to that is, no, this can't be happening. This is, I disbelief. This is, I must be dreaming. This is horrible. So the first, that we call it, in the United States, we refer to that as a deer in the headlights, a shock response. I don't know, is there a Portuguese deer in the headlights that you can say that? On the other end of the extreme is adjustment, that people are by and large resilient, and they adjust to even horrible circumstances, become the new normal that people adjust to over time from loss. So I had a really smart graduate student, and she's like, you have the, we've initially had just the frog in boiling water. And she's like, that works for end of life. Like Kubler-Ross was actually talking about dying cancer patients in Chicago. And she goes, but if you're talking about bereavement, the surviving person's not dead. They're not gonna get boiled in that water. So for that, our image is getting back on the horse. I don't know if that's saying. So getting back, so there are 2 poles of this theory. One is the initial response is shock and disbelief, and the final thing is some sort of gradual reintegration of what that loss means for you. So we tested it with the Yale bereavement study data that we had. We had these indicators and we assessed them on various scales. And the initial plot of these symptoms over time looked like this. Unadjusted, looks like this. And I was like, all right, so mostly people, at least they say, and people do report, I think there's some social desirability bias in acceptance, because even with our advanced cancer patients, everyone says that they accept it, but they also have really high levels of disbelief, which is sort of contradictory. So, but people say that they accept it, and it does increase over time from loss. That's true. My husband, Paul Maciejewski, he's a statistician, and he's like, you know, I see something different in these data. Let me try something. So I went out for a run. This was a long time ago. I come back from my run. He's like, you're not going to believe this. I rescaled it so that the data are answering the question, when are each of these 5 indicators maximally expressed? When's the highest amount of grief expressed? And what we found was this. The likelihood that, so when was the most disbelief? Obviously at the beginning. When was the most reintegration or acceptance? At the end. But all the other ones in the middle, which are sort of the debatable ones, were exactly in the sequence that Kubler-Ross had proposed. The likelihood by chance that that would have happened was 0.008, that this would peak, that would peak, that would peak exactly, those 5 indicators exactly in that sequence. So a lot of people hate this theory. I think it's a narcissistic insult because people are like, everyone's different. This won't translate, but that grief is like a snowflake. So you probably don't know what a snowflake is, but the saying is that a snowflake, every snowflake is different. And, or every fingerprint is different, and that everyone's grief journey is unique and different. And yes, everyone is not the same, unless we were all clones of each other. But are there systematic patterns in these responses? And these data do support that there are these kinds of ways, and that's excluding the people who get stuck, right? So what we did was, we took the same data, and I apologize for how crude, this was an early figure, but I like it because it really shows what we're talking about with prolonged grief disorder. You see the red people, they're the people who at 6 months, and now the criteria 12 months, we'll be getting to that very soon. But at 6 months, they met criteria for prolonged grief disorder, and we plot their grief scores over time. And then we took the people who didn't meet those criteria at 6 months and what their grief scores were like initially and at the end. And if it were true that there's no such thing as prolonged grief disorder and that they're not a different group, that red line would merge with the blue line and you'd get a purple line, and it would all come down together. And what you see is these people are stuck. These people initially, there is something called a delayed reaction, but by 6 and 12 months we find these people who are struggling with these relationships and feeling intense yearning and missing, that their life is destroyed because their love of their life is gone, that their life will never be the same and they won't experience joy anymore. Those people are different, and we're not trying to pathologize them. We have data that show they need help, and that and they want help, which is we'll be getting to the misconceptions, but these data support that there is a distinct group of people with prolonged grief disorder. So what is prolonged grief disorder? And it's this chronic, intense, distressing reaction to loss distinct from bereavement-related depression and anxiety. In other words, it's heartache. The main symptom is this yearning and pining and missing. You know, for children, like, how would you define yearning and longing? I'm pining for children. Missing. I miss my mommy. I miss them. And you feel it. It's in your soul. Your soulmate is gone, or your child has died, and your heart is broken. That's what. And are you sad and likely to be depressed? Yes. All right. Does that make you have separation anxiety and worries? Yes. We're not saying it doesn't, but we're saying that missing, that heartache, that I'm not whole because my heart's been torn apart because this thing I cherish, I love, is gone now, and I need to figure out what my life is going to look like going forward. So that's what this syndrome is all about. So, yeah, unlike typical grief, people with prolonged grief disorder are stuck, as that figure just showed. And we show the prevalence rate is less than 4% in community-based samples. It's different when there are high multiple traumatic losses occurring at the same time, different circumstances that we can get into later. But on average, the prevalence is in community-based, mostly older, widowed, bereaved people, which is the normal prototypical type of loss, that the prevalence is about 3 to 4% in community-based samples. So, you know, in the United States, I don't know I know different countries are more DSM, others are more ICD. I don't know what Portugal is. Good. Go team DSM. But actually the criteria can apply. I was actually invited to present on World Psychiatry Symposium by Mario Maj because there's been so much interest in this topic. And the question that I get all the time is, can like the PG-13 R apply to the ICD-11 criteria, and how generalizable, like does one size fit all? And the thing is that with the ICD-11 criteria, they're less strict. They give more power and influence to the impression of a clinician to basically determine whether this person meets criteria. So statistically, the measure for prolonged grief disorder is really, it's a unidimensional construct. It's really this heartache. You know, that's what it is. So can you measure it with these kinds of symptoms best, or those kinds of, as long as you're measuring that core construct and you think someone's really stuck and having trouble functioning because of it, and that they're just unable to get out of bed, they might be suicidal, they might be self-soothing with drinking or smoking or whatever, or vaping. That's what this disorder is about. So these are the criteria. I think most of you probably know. 12 months was required. That was a political, somewhat political. The data supports 6 months. You can detect in community-based samples who's going to be stuck, as those data really show. But there was going to be outrage at 12 months. There was even at 6 months. There was outrage at 12 months as well, but a little less. The DSM had an open period where there was public commentary on the diagnostic criteria, and the 12 months, moving from 6 months to 12 months, blunted some of the outrage. But the person has to experience most days throughout the day this intense, these pangs of grief, or Cullen parts called these pangs of yearning and searching and missing this person. And then 3 of the 8 remaining symptoms, like identity disturbance, loss of meaning, anger, disbelief, all the remaining symptoms there. You can use the PG-13. We have a smart PDF that automatically computes the score and provides a recommendation. The symptom scores of 30 or more are syndromal level, if you want to use that for just determining syndromal level of prolonged grief disorder. So now we got a grant from the National Institute of Mental Health to come up with standardized pages to help clinicians, mental health professionals, distinguish between normal grief and prolonged grief and depression in the context or the wake of a loss. So I'll be providing these videos. One of them, I've been told, really is more agitating for people to listen through than others. Hopefully you won't say that it is, but why don't we start with this one, which is not.
You mentioned on the phone that you wanted to come in today to talk to someone because your intern has suggested you needed some help.
Can you hear?
Definitely. About your husband, Henry. I'm so sorry about your loss. Why don't we start by just asking you how you've been feeling the past few weeks?
Well, I guess I'm just numb. Henry passed away about a year ago, and I just find myself missing him so much. He was my everything. He was my whole life. We did everything together. We were best friends. And I just haven't been feeling myself since he died. Yeah. I just spend all day long just thinking about how much I miss him. And I miss him so much it hurts. I mean, physically hurts. It's like this wave of pain. And when it doesn't hurt, I just feel numb. Like I'm kind of dead inside. You know, Henry used to make all the plans. He was a good man. such a source of support and guidance. I just don't know who I am without him. I don't know how to act. Sometimes I ask myself, what is my place in this world? I feel so alone. He really did everything for us. We planned our trips. We took care of the finance. I just can't believe this happened. Sometimes it's as if he's still here, but I just can't reach him. I've been sleeping in his pajamas. Is that crazy? I just like to feel that I can smell him. It makes me feel like he's not gone. I keep trying to keep busy so that I'll take my mind off of him. So I made this calendar, and I put down chores that I could do every day. When I'm not busy, all I think about is how much I miss him. And if I find something of his around the house, I just break into tears.
So sorry. Have you been receiving any kind of support from your family, even your friends or your community, anybody?
Well, I do have some friends, and they tried to help me. They sent food over after he died, and they invite me to go to lunch or two. But I just don't feel like it. They don't understand what I'm going through. So, I don't want to start over. I want things back the way they were.
In looking back on your life and on some of the challenges that you faced, sometimes it's helpful to know, are there any life experiences that this loss brings up for you?
Oh, yes, certainly. My mother died when I was very young, 8 years old. My father remarried, but my stepmom was very warm and loving. I just missed my mother so much. No one could take her place. So I guess that's kind of the way it felt when I lost Henry. But I guess I haven't any of the same worries that I had. I have to say that I don't know why he had to leave me. Sometimes I just feel angry. He promised me that everything would be okay.
Is there anything that's comforted you during this difficult time?
Well, I do smoke. And so when things get really tough, I go outside and have a cigarette. I smoke about a pack a day. I used to limit myself to 2 or 3. The only other thing that comforts me is being around him where I can feel him. I just want to be close to him. I don't like going to the places where we used to visit, even the grocery store, because they remind me of how much I miss him.
So that's a pretty typical PTD reaction. I don't know if any of you have seen patients or clients, and it's pretty typical. So I think, we have typical grief and depression. A show of hands, should I show these clips or get to the material? I think I asked that in a biased way. A show of hands. More videos? All righty. That we can do. All right, so.
Hi, Sandra. It's really nice to meet you. You mentioned on the phone that you wanted to come in today because your internist suggested that you needed some help coping with the death of your daughter, Jana. It's such a tragedy, and I'm so, so sorry. Why don't we start by asking you how you've been feeling over the past few weeks?
Well, my daughter died 14 months ago. So, yeah, I'm feeling really sad and missing her so much. Some days I'm fine, It's just when I'm reminded of her, that's when I get so sad and teary. I know, you know, my husband and the kids, man, we'll all be reunited one day. She said, I struggle getting back into my old rhythm. And Gina and I did everything together. She moved in with us when she came back from college. I have a t-shirt of hers that I clutch just to feel connected to her. I told my doctor that, I told her that, you know, I'm still missing Gina, and I mentioned I had her clothes and her things, and she said I should talk to someone. My sister keeps telling me, you know, get rid of Gina's things so I'm not reminded of her when I go in her bedroom. But I don't want to do that. You know, is that crazy? You know, it doesn't bother me that it's there. I like feeling connected to her.
You know, you mentioned your sister, and I'm wondering, are you getting any kind of support from family, friends, or even community?
Yeah, the kids are great, you know. We really lucked out. I mean, their husbands, their wives, they didn't want to, you know, they didn't want to be far away from the family, so they live kind of near me, so I can just go to their house for dinner.
Great, yeah.
And I go once a week, you know. And the grandkids, I love them. There's something else. This is how I get sometimes. I find myself missing her, and it's just like this, like a wave of sadness that just. I try not to focus on it, but I do try to remember the wonderful things, you know, just that we shared together. I try.
That's good.
Yeah.
Are there any, you know, challenging life experiences that this loss has brought up for you?
Like, have I lost anyone else before you? My grandmother died 6 years ago. It was sad.
Yeah.
But she lived a long, full life, and I guess it was her time, I think. I don't really remember my father, so he wasn't around much, and I don't know if that counts. It never really bothered me. My grandmother gave me and my brothers and sisters just all the love and support we needed, and so...
May I ask, has there been anything that's comforted you?
God. Yeah. God is my comfort. I am comforted knowing I can talk to Him. I can pray to Him for guidance. I thank Him for blessing my family and blessing my husband and my kids. Like I said, being around my grandkids, you know, they're wonderful. And being the first family of our church, it's the church community has been a blessing to us too, and the outpouring of love and compassion.
Nice.
For my husband, for our family, it hasn't stopped. You know, so many members of the congregation still approach me and share memories that they have of Jana and how loved she was. And I feel so proud.
So I think that's enough videos for now. But that's not pathological grief or prolonged grief disorder, and she has supports. One thing that the first example mentioned that I'm wondering, that struck me, is a lot of people have lost a parent as children, and for some reason the age of 8 seems to be a very common, you commonly hear that someone lost the mother at 8 years of age. And I do feel like there's developmentally some risk for prolonged grief disorder that we've noticed that happens with people who have childhood loss of a parent, particularly a mother, and at age for some reason. But I just wanted to share that if, I think that's clinically significant. Now, I'm not going to show Leonard. Leonard's the one that really bothers people. He's depressed, and he doesn't meet criteria for prolonged grief disorder. Everything is just heavy and bleak and uniformly sad. And so I'm not going to show him, but I am going to describe to you just a synopsis of how does prolonged grief disorder differ from major depressive disorder in the context of a loss. Yearning is not in major depressive disorder. This pervasive low mood, like Leonard, that are spared from witnessing, everything is heavy and sad and pessimistic. Whereas for grief, it's not. In fact, mementos bring joy, and it's very person-specific. It's not generalized to everything is bad. What's bad is that they're not with this person. So it's very person-specific. There are bittersweet emotions in prolonged grief disorder. Again, in major depressive disorder, low mood more universally. With major depressive disorder, there aren't these pangs of missing. It's not, missing is not, or yearning is not any part of major depressive disorder. Again, it's not person-specific. There are episodes, depressive episodes, whereas grief is either really high and intense and chronic, or it tends to be that lower group, the blue line, rather than the red line. Major depressive disorder evokes more of a feelings of low self-esteem and self-worth, whereas for prolonged grief disorder, it's that the person, part of the problem is that the person who made you feel safe, secure, who you were in the world and your relationship to everyone else is now gone. And so it's very your worth was so intertwined, and your sense of who you are was so inextricably bound with this person. So that's the piece of you that's missing. Whereas major depressive disorder is not that. Yeah, so those are the main distinctions with major depressive disorder. With PTSD, again, no yearning or pangs. If anything, it's avoidance. You don't want to think back to the traumatic loss, the horrible situation, because that's frightening to you. Rather, in PGD, it's this yearning and wanting to turn back the hands of time. Yeah, there are avoidance of reminders of the death, whereas here there aren't avoidance of reminders. There's actually seeking out and even imagining in PGD that maybe this was all a big mistake. Imagining going to a football game and seeing someone who, you hear that all the time. You hear that people imagine that there was someone that looked just, you could have sworn it was your deceased loved one. That doesn't happen in PTSD. PTSD is event, experience, fear specific, whereas this is, again, person specific. So we've written about, and you can distinguish between these two syndromes. I think I've really, if you have questions, we can talk about that later. Regarding some of the many misconceptions, so there's been claims that it stigmatizes the mourner. So and these claims of stigmatizing the mourner have been based on studies that haven't talked to bereaved people. And they've been hypothetical situations where you ask, if you were to see someone who had these symptoms, would you look at them differently? Do you think you would react? I don't trust hypotheticals. That maybe if you do, it's your belief, you're fine. But in terms of hard evidence about feeling stigmatized and feeling that people think about you differently or less, you have to ask person who's in those shoes. In the United States, there's a very common phrase that's overused. It's called the lived experience. But you need to know what does it feel like to be a person who's given that diagnosis, and for someone who's mourning who has it, and someone who doesn't have it, and how does that differ, and what do they, so we ask people. We ask people who were bereaved in the community, not patients, not clients, and and some of them met criteria, some of them didn't. We asked them what they felt. And 90% of the bereaved people that we interviewed in that survey said that their family members would be more understanding if they were diagnosed with PGD rather than less understanding. That the diagnosis actually provided a sense of comfort because mental health professionals would have a better grasp of what they were stuck and what their suffering was about, and hopefully know how to treat it, which is another misconception. One of the misconceptions is that we're paid for by big pharma or drug companies to push pills, that we're making money. We have a financial incentive to pathologize people because we're going to make money by selling drugs to them. The people who've come to, I'm not a clinician, I'm a researcher. By and large, I'm a researcher. I've been studying this for many, many years. I've played too long that. But since 1995, when we first published the Inventory of Complicated Grief, every single day of my life, I get emails from around the world, people telling me that they've been stuck. Some of them have been stuck in feeling these symptoms for 20, 30 years. It could have been that their mother abandoned them. But these issues stay with some people more than others, and we're not trying to label or stigmatize somebody or medicalize a condition. People are coming to me inappropriately because I'm not a clinician for help. 100% of those people who met criteria for prolonged grief disorder in our survey said that they wanted treatment. They wanted someone who understood this disorder to know what to do to help them because they were stuck in this very distressing, so distressing that it is the mental disorder and bereavement that poses the highest risk of suicide. So it's not that this yearning and pining is necessarily normal and natural, and with time, the vast majority, we're seeing like 96% of people are likely to, they're not going to be happy about what happened. They are going to feel grief like the person we just watched, but 4% of the people in the community are that at-risk group, and they need something different because antidepressants have not helped them, and interpersonal psychotherapy did not help them. So they need you. They need people like you to understand what are their issues and figure out what are the ways and approaches to helping them get the most out of the rest of their lives, rather than to be in that chronic state of missing somebody, that always feeling less than, or being robbed of your true love or your child, or walking around just with that burden. That's what this is all about. So I won't belabor much more all the various misconceptions, but we have data that there were claims that there wasn't enough evidence in the published literature. We're not the only people saying it. There are over 1,000 on prolonged grief disorder alone. In the peer-reviewed literature, there are over 1,000 publications on prolonged grief, not complicated grief, not other types of grief. There are 10 systematic reviews of all the research. So we were told by Michael First in the DSM that there was more evidence to support the inclusion of the prolonged grief disorder than there was for post-traumatic stress disorder in 1980. So the misconception that this is just we've been called a group of researchers that's really been just advocating for this pathologizing of normal grief. There's evidence from not just us, from around the world, from researchers like you, validating the scale, thank you, in a variety of different cultures. That's not to say that grief looks the same or feels the same. The lived experience isn't different in every culture. We've done studies, some cultures don't even have a word for grief. Relationships and the meaning, in Spain there's a viuda, and in India there's widows used to have to annihilate themselves on a funeral pyre. There are cultural influences on the manifestations and how people think about mourning rituals. And some of them, you know, should be fair and to share, maybe overshare. But during COVID, my mom died of COVID. And because of the pandemic, we weren't allowed to bury her. I'm Jewish, and we were not allowed to. You have to bury very quickly, and it was a horrible, as bad as a mother's death is in general. It made it worse not having these rituals, and we had to forego it for about 9 months, and then we did a ceremony by her gravesite with singing songs, and we had a rabbi there, and I hadn't slept for 9 months. I was grinding my teeth, and after that ceremony, it was like a huge weight had been lifted. So I do think that some of these cultural influences on helping people and support communal, interpersonal supporting people through significant losses is hugely important. But I also think that as mammals, like prairie voles, monogamous prairie voles and oxytocin, we are connected to each other. And when someone significant dies, we feel it, and we feel it in our hearts, and we need to support each other through grief. All right, so let me introduce our microsociological theory of adjusting to loss. So my husband's more of a basic science, not more of, I'm not at all in science. But he quotes Aristotle, who said that nature abhors a vacuum. He was a mechanical engineer by training. Physical, when there's a hole, things fill it up. And I hear it as a social scientist. And I said, you know, there might be an analogy to an interpersonal loss. When your social space, your social world is deprived of someone significant, it creates social voids that need to be filled. So we think that even in psychology, there's been a lack of attention on the social deprivations that a significant interpersonal loss creates. So what am I talking about? I'm talking about feelings of nurturing. So I think it's pretty well known that you know, when someone you love, then a significant other, partner, spouse dies, you feel a loss of someone to care for you and to nurture you and support you and make you feel whole. So all those, in sociology, Cooley had talked about the looking glass self. That person who's the mirror against which you see yourself is gone. So how do you see yourself without that reflection? When this other person helped you define your roles in the world is no longer there, you need to figure out a whole new way of relating to everyone else. There's a social, interpersonal gap that's missing. One thing with my mother's death that also dawned on me was that not only did I miss her caring for me, she was older, and I missed caring for her. I missed, you know, showing my love for her, showing that I could do things that made her feel special. And I think that there's I think people don't think of a need, but I think there's a need for mental health for people to care for things and care for things that they love, like a pet. That's why people have pets. Why do people have plants? I think there's a human social need to care for other living things. And when someone you love dies, that opportunity to show your capacity to give it back you're deprived of those opportunities, and that's a loss. And so I think as mental health professionals, if it's such an important part of mental health, interventions should be designed to address those types of interpersonal losses. There's a loss of how you see yourself. There's a loss of meaning and purpose and where you fit in for holidays and those sorts of things. The other sort of novel type of loss is this idea of a loss of what's comfortable, like an old shoe. So an old shoe is very comfortable, and an old relationship is very comfortable. And when you've been married to someone for 30 years, there's an ease of, you don't need to think about, you can answer you can complete their sentences for them. You know where they're coming from. They understand you. And so when we've developed these simpatico, like loss, web pairings. It's like a matchmaking service for people who are bereaved. And there's some literature that shows that support groups, bereavement support groups, are only as helpful as the pairing, feeling that that person had the same lived experience, the same, a mother who's lost a child to a drunk driver is different than an older child of a parent who has Alzheimer's disease and has died. So having a support group or a support person who's matched on similarity in terms of cause of death and kinship relationship to the person who died is key. So we've developed a simpatico algorithm to try to pair people. And also, ultimately, we would like to pair them on interests and values. And so that in the United States, there's programs called Meetup, where they would say, oh, you like opera? Great. Joe likes opera. He's also a mourner like you. Why don't you, our baseball game, go, like it's happening tomorrow. Why don't you, click on here and you and Joe go to the baseball game. So we're trying to have a web matchmaking algorithm. That's apparently, my daughter told me, it's a lot like Hinge or matchmaking apps. But the part of that, so we also have a web app that also, a lot of older widowed people are rusty socially. They've been with the same partner for 30 years, and there's a sense of comfort and ease in that any new relationship which we might match someone with, there's also going to be inertia. And it's as wonderful as this new person. So we cognitively reframe, no one will ever take the place of the person who died, which is true. So we reframe them, new frame, we have them literally in old frames on the web. We have them take that negative bereavement cognition. No one will ever take the place. Be as good or understand me or love me like that person who died. And we reframe it, we give them 5 options of different reframes. And we say, you know, maybe they won't love you the same, but they'll love you in different ways and for different things. They'll be better in some ways. So we have them, and we move it to a new frame. So we have them reframe their negative bereavement cognitions. But the one thing we can't really do is all these new, you know, what the bereaved person is thinking is, I will do my best and try. But it was so easy. It was so, I didn't have to do, the new normal is so much work. And a lot of people are older and they're stuck in their ways. So we try to make it as easy for them to connect with others and fill those social voids. Because the easiest thing to do is to just stay home and look at old pictures and say, my good days are behind me and the future is bleak. And so those are the sort of interpersonal mechanisms through which we think it's really important, especially bereavement is an interpersonal event. It's an interpersonal loss. And so the ways to help people adjust to life and get the most meaning out of life moving forward is through interpersonal interventions. So that's our theory about, and that informs our living memory home, where we have online journaling for narrative disclosure, which we found it wasn't even our living memory home, where we have prompts and we have them write a condolence letter to the deceased person, and we have them say things I never told you but wished I could, and a place to sort of compartmentalize their time and place with the deceased person. So a lot of bereaved people worry about forgetting the person. Like as special as they worry that they won't remember this person. And they worry that they will disrespect that person by sort of moving on. They feel guilty about that. So we the living memory home provides a place for them. It's like putting it in a box, online box, where they can, a time and a place for them to pay respects, and once they can compartmentalize that, they can go about their day. It's almost like a secure attachment. Once you have that secure attachment, you're good to go and explore your environment. So that's what the living memory home does. It was not intended initially to be therapeutic. There was a pre-med student who spent a summer with me. Her father had died of pancreatic cancer, and she developed it. And I'm like, this is lovely. Let's put it online. So we did, and then we correlated it with their grief scores over their entries. And lo and behold, the more they wrote and the more they logged in, there was a significant drop in their grief scores. So I said, this actually seems therapeutic. So we have the living memory home. We also have a suite of applications we call Finding My Way Forward Through Grief, where we have them practice social skills, and we have them draw a social map of who's in their social world, and we have them figure out who does what well and who does what in a not so good way. So for example, some people have friends that have a really nice car, and or have membership at a club, or something that practically they like, but they're not very good listeners. Other people are really good at hearing and understanding you, but they may not. So we have them sort of draw who is in your world and who isn't in your world, and what are your needs, social needs, prioritizing them. And then a lot of these people will have very rusty social skills. So what we do is we give them practice conversation starters and ways to get the conversation going if they were to meet somebody. And what to say, because a lot of older widowers, for example, their wives kind of help them socialize. So they need some practice. So we provide that online. So our suite of services has all these online tools, including Simpatico, Living Memory Home, and connecting with others, and a cognitive reframing exercise. So this is really, I'm not gonna, So now I'm at Empower. Should I stop? No. Okay. So this is, I apologize for how long it took me to get here, but this is probably what you wanted to hear about. So Wendy Lichtenthal and I developed Empower to provide the context for developing it. When I came to Cornell from Harvard, I was met by the director of the medical intensive care unit, and he said, you're so focused on cancer and bereavement, focus on family members of people in critical care dying in the ICU, and focus more on their psychological needs. Don't interrupt the family meeting where you're discussing advanced care planning, which was a lot of the palliative care interventions, but rather focus on helping us work with this family surrogate. We have new interventions where we call this family surrogate a co-patient, because we have increasing evidence of just how helpful the co-patient or family member is to orchestrating and providing better end-of-life care for a dying patient. So that was the backdrop where the critical care docs were coming to us and said, families, members of people who are dying in the critical care unit are so upset, they won't sign a DNR order, they won't do the things that will lead to a better quality of death because they're in denial, they don't realize what's going on, and they just need help. There have been several palliative care interventions that have attempted to intervene with palliative care interventions in the ICU to reduce outcomes of psychological distress. They not only failed at improving psychological distress, I don't have that, but they've increased the odds of PTSD threefold by re-traumatizing the patients, even though they met as sort of like critical incident stress reduction, where they were not you guys. They were not mental health professionals, and you can do more harm than good. So we're like, you need a mental health, and psychologists know how to address trauma and grief, and they've been doing it effectively for years. Palliative care interventions have not been informed by very well-established, proven insights. So Wendy and I said, why don't we get the family surrogate? The critical care team tells us there are ample number of family members who are just crying, unsure of what's going on with the patient. They refer them to us if they are very anxious, distressed, and or emotionally dependent on the person, because a risk for prolonged grief disorder is that very close dependent relationship. Either of those are risk factors for poor psychological outcomes, so we get those people. I don't know if I need to share with you what Empower is or does. Yeah? Okay, so the first thing, we start with mindfulness, meditation, and breathing. Have you guys been following in JAMA in the last 2 to 3 weeks? They've been publishing all sorts of research on Tai Chi and meditative movement-related Tai Chi. And they even show that Tai Chi not only helps with anxiety and mood, it helps with blood pressure better than physical exercise and sleep. And Tai Chi, well, in Empower, that's where we start. That these mindfulness, so 3 minutes, they're in the ICU, 3 minutes of calming someone down. Their pulse goes from like 130 down to 80, just by calming them down. So we start by just calming them down. And we obviously acknowledge that it's a very it's normal for them to feel extremely upset. And I have a show of hands, how many of you have visited a critical intensive care unit? For personal or professional reasons? Personal reasons. Oh, no. For professional. Really? Really? So it is a scary place with beeping and screaming, and I learned about ventilators and dyspnea, and they're not, like, people are suffocating, and ventilators it's a very, very trauma. The staff they all have PTSD. They say, seriously do. They need Empower. That's a whole separate study, but they come because I think people almost want a sense of mastery to work in that environment to show that they can deal with it. But anyway, so we acknowledge how traumatic it is. We do this meditative thing to calm people down. We provide psychoeducation about what experiential avoidance is. And this is where Wendy Lichtenthal taught me the importance of addressing and confronting avoidance. And I know that there's a literature on resilience, and people have said how Rich Bonanno's been resilience, how resilient people are, and how people mostly overcome trauma. But what our data show is that addressing experiential avoidance is hugely, avoiding does not, it might feel better in the short term, but you pay for it psychologically in the long term. I think a lot of people think, if I ignore it, it will go away. And what we've learned, and our data show, ignoring it does not make it go away. It feels better, less threatening, but in order to get through it, it gets worse. So our data even support that. And one of the sort of, so anyway, we give them a psychoeducation about, yes, it's unpleasant to feel, to be exposed to uncertainty, and we enhance distress tolerance. One of the aspects of Empower that we've told is the most unpleasant, but also the most effective, was we asked these family surrogates to imagine the worst possible thing that could happen to them. And our first empoweree was a caregiver, an adult woman who said, I've been caring for my mother her whole life, and if she dies, I will go to pieces. That is the worst possible thing. When we role play with them, ask them what it would be like, what they would want for the person. We ask them how to negotiate those relationships. And what we find is, invoking the patient's role and this role play, so that we recruit patients who can't talk and tell the family member what they would want. So we invoke this role play where, what if they could speak to you, what would they tell you? And we show, so the results are really good. So I'm really proud of this intervention. So it's an intervention to empower family surrogates with tools of psychoeducation and experiential exercises. It's 6 15-minute brief modules. So they're in the ICU. So that's one of the main novelties is in the ICU, a lot of people feel bad leaving the patient's bed and not being there. So there might be a medical crisis and they might have to leave. They might want to do it over 2 or 3 days. Or they might want to do it all in one sitting. Whatever they want is fine. It's only, I think in total, 180 minutes. And then there's 2 weeks booster sessions, which I was like, do we really need the booster sessions? We really need the booster sessions. So the data really support that it's that continuity and follow-up of a caring person to just give them that social support that they need later on in this very upsetting period. Now, one of the things that we found, I don't know if so I mean, you probably have the manual, and I don't need to go through what the manual is. But the results were really very promising in our pilot work, and they're even better in our randomized controlled trial right now with Miami and Memorial and Cornell. Overcoming experiential avoidance, it got worse before it got better. So people, but the only way, it appears that saying the only way through it, around it is through it. That you need to experience that loss. What we showed is that you can see the results. There are large effects for grief specifically, both pre-loss grief as well as post-loss grief. About half of the patients died during our study observation period. So just to be clear, we are getting family members as their loved one is dying and recruiting them to do a study, which is a big ask for them. This is probably one of the worst weeks of their life. And one of the main take-homes is we are not even attempting to make patients, family members, happy or improve their mental. It's not over baseline, improve they're coming in very, very upset. The sad thing is I don't know if I have the results that can show it graphically, but we have strong effects for anxiety, PTSD, experiential avoidance, and decisional regret. So that role play really helps reduce their regrets about the care received at the end of life. Oh, I'm sorry, I don't have it here. The main thing with Empower is without it, the people who got enhanced usual care, their psychological distress went off the chart. Like it was really, it's the worst week of their life, and it was getting, without this intervention, it got significantly worse. And with Empower, it got a little bit better. So the significant effects of Empower were mostly protective to make sure you didn't psychologically sort of fall off that cliff in that very vulnerable period. So those are the sort of realistic goals. This isn't sort of a wellness retreat or a resort where you leave feeling relaxed and it's really a protection against the distress and trauma and grief of someone who's experienced a traumatic interpersonal loss. So those are the goals. And then I can talk about naltrexone or not. I realize I'm way over. All right. Okay. So I can naltrexone. The one thing I will say is that the idea for naltrexone came from a an appreciation of the neurobiology of grief, which is that there have been studies by Mary Frances O'Connor and others showing when there were pictures of the deceased, those who had high levels of grief and yearning were, when the nucleus accumbens, the reward center of the brain, lit up when they saw their deceased for those who had high levels of grief, and it didn't affect depression. So there have been all these studies that show that, you know, naltrexone affects blunt reward. That's why it's used for opioid, to get people who are have opioid addiction. The idea, so we've been criticized because the notion there was that naltrexone would make people socially disconnected. So they said, you're trying to medicalize grief and give people a grief pill that will make their grief go away, and medicalize it so that it's in the hands of medical professionals, and it will blunt their connections with others. And I said, what is the evidence that that will happen? And the evidence was our protocol that hypothesized that it would actually blunt reward of the deceased close other. They also cited a study that has used naltrexone that showed naltrexone in college students who weren't bereaved, that it blunted social connections in people who they were very close to, but had absolutely no effect on the relationships to people with whom they were not close. So that is consistent, not against our theory. Our social theory of adjusting to loss is, in a Freudian sense, you need to decathect from the reward of a dead person to open you up to make new connections, and then hopefully develop into close relationships in the future. So for a time, you're stuck. You're stuck thinking this is the thing that I want. And anything that can help you get unstuck should help let you leave your house and stop looking at videos and pictures of the past and re-engage with new people, maybe through some simpatico or something. So we have piloted it in Boston. Some colleagues in Brazil have successfully used it on several people, and it was fast acting, and they had people who antidepressants and psychotherapy had not helped, but with naltrexone they were leaving the house and engaging in life and caring for their grandchildren, for example. Very small sample, nothing published yet, but the notion that it would harm social interactions, there's no evidence of it. And where we come from is research and evidence is needed to determine how it affects these things. We're not pushing this. Only people who are feeling distressed by their grief and that nothing else has helped them come to us to try naltrexone. I no longer am doing that trial because I'm not a clinician and I don't want to be doing that. But do I think that it's worth a shot to trial it and see if it's helpful to people in a systematic, rigorous way? Absolutely. I don't think the naysayers who disparage research are really doing bereaved mourners who are desperate for some help and service by saying we shouldn't even study it. So that's my plug for the naltrexone study. And now I will end my talk. So we've covered what the diagnosis is, what it isn't. We've covered the social theory of deprivations and why we think the social losses are key to helping people adjust to life in the wake of an interpersonal loss. And we've even discussed very briefly in power and naltrexone. So thank you very much.
I would like to ask you something about the graph you showed in the beginning of your presentation, where you can see the phases, namely disbelief, and anger, bargaining. there is, I seem to at least think that there was a great gap between one of the first 4 phases, you know. I think it was depression, and then there is a place where depression has gone down quite drastically, and acceptance is still in its way up. There's like this big gap when there's no line going on. I was curious.
So we assessed these 5 indicators, and the theory had that acceptance. So the gap is that we wanted to use all the data for the whole temporal observation period. We had the same acceptance earlier, but we were testing the theory like whether it was the last. When did it peak? And we followed. So we followed them to the end of the study observation period. It was 20 some odd months. So that's, and the plots for the final figure where we show when each of them peaked, those are smooth averaging the data over time. So the first one, the first graph was the actual raw data, the course, but the one that showed acceptance, that curved all the way over time, that was averaged all those assessments over time. The plot is the smooth graph of all the data over that time period. But we wanted to take it out as far as we could for our last assessment when we have data.
So there's already acceptance. There are already the phase of acceptance, but it keeps going up from time. It reaches its maximum later, but it's still present.
Right.
Okay. Thank you.
No, and it's actually an important point because we actually also plotted. We had a paper in 1999. It's a little odd. 1999, British Journal of Psychiatry, where we plotted acceptance over time for the whole sample, not. Well, we did actually both ways, and disbelief and shock. And what we found is, as you said, acceptance, and even the raw data showed acceptance was really high, even initially, so it's getting higher, of course, over time. Disbelief was highest initially, right? Shock and disbelief, deer in the headlights. And then but it was almost a mirror. I don't think I have it in this talk, but we plot disbelief and shock and acceptance, the two opposites, and it looks like this over time. So I think that it's like that's not a coincidence, and I think that acceptance and the shock and disbelief are opposite sides of the same coin. So as you start accepting and the death, you're no longer in shock and denying that it happened and that this is your new life. And that comes with whether that acceptance is necessarily peaceful or that's a whole separate debate. And we also don't like that word acceptance. We think the word acceptance is wrong because that's a high bar. Like acceptance is like, oh, yeah, it's okay. It's all good. No, it's not. It's more of like a reintegration. Even dying people, as people get closer to death, you can see that look in their eye that there's this sort of they're off in another they're disengaging and detaching, and it's like they're in their own world and new normal. We actually want to develop a version of simpatico for dying patients because I think dying is very lonely because you have no one who's died can tell you how it went or can give you advice. So you're on your own and you're so weak and debilitated, and it's got to be you're like and I don't know whether other dying people will necessarily embrace or even want or feel the capacity to connect with someone. That's an empirical question, but it does occur to me that this acceptance of your impending death must be a frightening kind of realization. Or maybe if you're old and you're like, this is life. Maybe there's an awareness that this is how things go. But you might be comforted to know that you're not alone. Because I just think we're social people, and being alone is scary, you know. And so those are just empirical questions that I do not have the answer to. But
Hello.
Hello.
Thank you for sharing your knowledge and your experience. It's very enlightening to me. It brings a lot of questions. One of the researchers, you spoke about the ICU. It means a bit to me. And I was thinking that is challenging because these family caregivers are such in a stressing phase. So how is the appropriate approach to this family, to these family members that are going through so many questions? And so how is to do research and your trials in this context?
That is an excellent question, because initially we had trouble because the people who needed it or who would potentially benefit the most were oftentimes like, I'm good, I don't want help, like just leave me alone, I don't want to do, and also it's a research study, so that's another, like, why are you asking me to do research, right? Like, it just, you almost felt bad, but you're trying to address that. And I was that daughter. I was that daughter when my dad was dying. He was a physician dying of pancreatic cancer, and I remember just like, I wasn't sure he was dying, and I started just crying, and everyone around me was acting like it was, you know, Tuesday, and I'm like, isn't there something, like, I think people, not everyone will want someone there to support them, and we initially had to perfect our approach because it was hard. It was really hard. The people who needed it the most were in no shape to be signing on for it. And so one approach we were told by our Duke colleague, Christopher Cox, was he created sort of like testimonials, advertising testimonials of people who had been through the program to say, you know, I didn't feel like doing it, but I got so much out of it. And I am so eager to hear about your experiences because, you know, you do feel bad. You feel bad like doing research and intervening, but you're doing it because the critical care folks, me personally, some want, many need and would benefit from that level of support. And the other thing is palliative care physicians also don't want us talking people out of signing a DNR or into signing a DNR. We are agnostic. We are not saying, I don't know whether that in Portugal that's an issue, whether in the United States, over-treatment and the hospitals, the default is you intubate, you resuscitate, you do everything, and for nothing. It's just so expensive, and it's traumatic, and you're breaking bones for nothing. They're going to die, like, why, you know? So, but that said, we are not pushing or preventing. The role play is just to help the patient. We recruit patients who can't talk, and that makes the burden on the family surrogate even more, because it's all on them to decide about end-of-life care. So we're there to help them think through that and provide them with that support. And whatever we've done, and I keep asking my team, because they've gotten good at it, they did, like, there is we were not very good at it, and we had trouble. I'm like, they need it so much. The critical care team says that there are all these people who would benefit who are declining. We've adapted it to the PICU, parents of kids who will likely live. And the PICU parents are embracing it. Like, they are eager to, we don't have that problem there. So our team has figured out, because our recruitment rates are really good now. Like, they figured out an approach that really works. So maybe there could be a Zoom. I don't know but you're not doing it in the ICU.
No.
No. But if you were to do it in the ICU, we've learned something. So we're more than happy to share what worked, at least in the United States.
Thank you. Thank you. Yeah, I really like it.